Good morning, all. This is an important module, cardiorenal monitoring during weight loss. We'll try to interpret a rising creatinine and how to write sick day rules. The creatinine rose, three mechanisms, three different responses. So the patient is on one drug. We need to think mechanism of rising creatinine before blaming the newest drug. So a patient whose creatinine rise by 35%, whether it is a drug toxicity or a signal asking for diagnosis. Again, we'll try to understand three mechanisms and three different responses. If this 35% rise in creatinine happens, how we should approach, whether we should stop an ongoing therapy or we should wait. We should try to understand the pathology behind that rise, and then we need to decide. So we will discuss this through one case study. 58-year-old lady, Kavita, who is suffering from type 2 diabetes for a long time, more than 10 years, obese, CKD, G3. We don't know about the A1, A2, A3 criteria, but she was on ramipril, dapagliflozin, furosemide more than years. 12 weeks ago, semaglutide was initiated. There was 9 kg weight loss, along with a marked improvement in quality of life. But for last 2 weeks, the patient was having severe nausea after a viral infection and associated with poor intake in terms of food, in terms of water, and she had done creatinine for the evaluation of this weakness. And what was she found? She found serum creatinine was 35% elevated. Now the question arises whether we should stop semaglutide, because the last drug which had been initiated to this patient before this viral infection, though it was 12 weeks ago, was semaglutide. So whether we need to stop semaglutide, or we can continue everything, or need to have some pause and phenotyping of the patient. So very important to note, when we talk about serum creatinine elevated by 35%, it is not just equal to GFR going below 35%. Because when there is rise in 35% of serum creatinine, actually it comes around 25 to 27% fall in filtration. But again, if we try to just make it translated from creatinine rise to GFR decline, we need to assume the stable creatinine generation and elimination. So we are assuming an hypothetical steady state condition. But we know during acute illness, what happened? Creatinine dynamics changed. Creatinine lags behind the change in GFR value. So whatever eGFR we are calculating, we are assuming a steady state. So this calculated eGFR actually misled us. So a larger change triggers evaluation, not automatic attribution to the most recently added therapy. If we talk about KDIGO 2024 guideline, and people with CKD initiating hemodynamically active therapy, very importantly, hemodynamically active therapy. For an example, it could be SGLT2 inhibitor, it could be SE inhibitor or ARB. More than 30% GFR reduction on subsequent testing exceeds expected variability, and that warrants evaluation, not stoppage, but warrants, of course, evaluation. But this is not happened in our case. So if we try to understand this creatinine change, as we were mentioning, there could be three different mechanisms. Number one, there could be change in the filtration. So here, no demonstrated structural injury, expected hemodynamic adaptation, and potentially reversible perfusion-related fall in GFR. So what should be our objective? We need to contextualize the patient, monitor, and restore the perfusion if depleted. Next, the creatinine changed. The GFR may be relatively unchanged because there could be altered muscle mass. As we know, the patient were on semaglutide, all the anti-obesity therapy, there is a probability of muscle loss. And as there would be altered muscle mass, muscle is one of the very important source of creatinine generation. So there could be altered creatinine generation. And there could be certain drugs which affect tubular secretion. And of course, we need to also acknowledge the assay-related issues and other non-glomerular filtration rate determinants. So generally what happened when there is muscle loss and less creatinine formation, so creatinine value will be decreased, pseudo increase in the GFR value. So for that, our response should be review the trajectory and consider the cystatin C based eGFR calculation. And there could be another third possibility, the kidney disease. So it could be structural or obstructive pathology, be it tubular or interstitial injury. Rarely we know even the pantoprazole can cause interstitial injury. There could be some active glomerular disease or obstruction or true CKD progression. So our response should be investigate promptly, identify and treat the cause. So the medication decisions follow the mechanism. Just only seeing the percentage and the patient was being initiated with semaglutide, we can't stop it. Mechanism, we had discussed three mechanisms just now. They may have some overlap and may evolve over time also. So these three questions before attributing the rise: perfusion, pattern, and persistence. When we talk about perfusion, whether the patient is in dehydrated state or congested state, there is volume overload or not. Because the patient was having vomiting, nausea, less intake, or sometimes it could be associated with diarrhea. We need to check for the orthostatic hypotension. Other symptoms like dizziness. The weight trajectory is also important to note here. The patient was on furosemide, so diuretic exposure, need to check the congestion level with JVP, whether it is raised or not, edema is there or not. Then the pattern, whether it is an hemodynamic insult that lead to rise in creatinine or direct kidney insult. So for that, the clock is important, the temporal relationship is important, whether it is illness or the drug initiation or escalation in the dose of the drug lead to this pattern. So for that, the biochemistry important, especially the bicarbonate, ketones, anion gap, they are essential, especially the patient is on SGLT2 inhibitor, whether we are dealing with one euglycemic ketoacidosis, other urine analysis, microscopy, the SCR value, whether the patient is on NSAID or sometimes patient took NSAID. We know there is one viral illness. Patient may have myalgia, and for that, he or she can take some over-the-counter NSAID. Sometimes it is very important to note if the eGFR is below 60, the patient had been exposed with some contrast, maybe some contrast enhanced CT scan, patient is on maybe on metformin, that may lead to rise in creatinine level, fall in eGFR value. And of course, the patient is having intercurrent infection, and that may be the reason behind this hemodynamic insult or even the direct kidney insult. The next important P is the persistence. That means whether that creatinine rise was transient or evolving. We need to correct the reversible factors safely, repeat the serum creatinine, electrolyte value, monitor the urine output, whether it is recovering, patient is in stable state or continuing to rise, whether some new hematuria or increasing albuminuria. Also, we need to acknowledge certain red flag signs. There we need to act immediately. Oliguria or anuria, rapidly rising serum creatinine, hyperkalemia acidosis, active sediments in urine, pulmonary edema, bilateral basal crepes, suspected obstruction. So, in our case, Kavita, actually the clock does not fit an initiation dip because there was long-standing ramipril, DAPA, and furosemide more than 1 year. 12 weeks ago, the semaglutide was initiated. Weight loss was there, around 9 kg. Last 2 weeks, when there was some viral infection, persistent nausea, inadequate intake, and after that, the creatinine rise to 35%. So the new event is gastrointestinal intolerance associated with certain viral infection, probable volume depletion, and that was not associated with SGLT2 inhibitor initiation. This condition may be aggravated by the SGLT2 inhibitors. We need to have a proper sick day rule plan. That is what we will discuss today. So, as per the clock, as per the temporal relationship, as per the exclusion of other condition, our working diagnosis is it is a case of probable volume depletion associated hemodynamic kidney dysfunction. Of course, euglycemic diabetic ketoacidosis, intrinsic injury, infection, and obstruction need to be excluded. So our immediate response should be, in this type of case, define the phenotype, whether it is a dehydrated case or congested case, whether there is some volume overload or volume depleted status. Check the serum creatinine trajectory, how it is changing, The creatinine dynamics already we had mentioned. In acute illness, creatinine dynamics changed. Need to check potassium, bicarbonate, urine output, any active sediments are there or not. We need to exclude euglycemic ketoacidosis. For that, the ketone body estimation from blood, the beta hydroxybutyrate is important. If it is not available, sometimes we need to check for the urine ketone bodies with bicarbonate with anion gap. If depleted, if dehydrated, then we need to rehydrate cautiously without provoking the congestion and temporarily adjust the medications according to the physiological need. And very importantly, not only withdraw those medication, also plan how to restart them when the patient become stable. This is an important slide. I think we need to go very slow with this particular slide, though it is a very busy slide. So as SGLT2 inhibitors, they follow a pattern, a tip pattern, and even we can see a good number of patients who were on a famous empiric trial, 10% drop in eGFR within first 2 to 4 weeks. But they had recovered that tip, and we know there was benefit in terms of renal outcome with SGLT2 inhibitors. So soon after SGLT2 inhibitor initiation, typically evident within 2 to 4 weeks, this tip. But illness-associated dysfunction, a new event during vomiting, poor intake, fasting, or acute illness. The trajectory is very important. When there is an expected initiation dip that is usually modest, reaches an early nadir, then stabilizes or partially recovers. But illness-associated dysfunction may continue until we correct the perfusion, ketosis, or any other cause. The clinical context, generally the expected initiation dip with SGLT2 inhibitors. In this scenario, the patients are clinically stable, no new volume depleted trigger, but illness-associated dysfunction. There are weight loss, orthostasis, hypotension, dehydration, or sometimes it could be a euglycemic ketoacidosis. Urine and laboratory pattern, usually bland sediment in urine. Glycosuria is as expected, but illness-associated dysfunction associated with those rise in ketone value, anion gap, potassium, bicarbonate estimation, sediments need to be checked, and also sometimes urinaries here help us to reveal a competing cause. Clinical response, generally the expected initiation dip with SGLT2 inhibitor. We need to check, we need to monitor if it is more than 30% eGFR fall or some non-stabilizing course, then we need to think about withdrawing the drug. Illness-associated dysfunction, generally withhold when clinically indicated, rehydrate the patient, investigate, treat the cause, and define the restart plan, when to start again. So an initiation dip has a clock definitely. Do not use it to explain a new event months later. So in this case, the SGLT2 inhibitor was there for last 1 year. So of course, here we need to plan for temporary withdrawal. As we were mentioning, when there is weight loss, that can make creatinine reassuringly wrong. So if lean mass falls, there will be less creatinine generation. So serum creatinine falls and we would have sometimes rise that is less than expected. So actual condition is much poorer compared to what picture we get. And that is why eGFR may appear falsely reassuring. So what creatinine may conceal? Falling serum creatinine may overstate renal improvement. Stable serum creatinine may coexist with falling filtration because that time the steady state had not been reached. And weight loss alone is not evidence of improved GFR. We need to escalate the measurement when it matters. So therefore, there is a role of adding cystatin C and calculating the eGFR creatinine cystatin best. Of course, we need to acknowledge certain factors associated with cystatin C based estimation errors like adiposity, inflammation, thyroid dysfunction, patient is on glucocorticoids. Measure GFR when uncertainty remains, like narrow therapeutic index, serious toxicity, decision close to a critical threshold. Our central takeaway should be a better looking creatinine is not proof of better filtration. So T index only when body size, the drug level, and the dosing threshold make it relevant. De-indexing changes the units. It does not correct the biomarker bias. That is what we need to remember. So, SIG-Tech choreography is important, and that is so the rule is how to plan for a pause, protect, and then restart. So when there is vomiting, diarrhea, markedly reduced intake with dehydration or ketosis risk, we need to pause, we need to protect, and then again plan for the restart. So for SGLT2 inhibitors, pause with poor intake, dehydration or ketosis risk. Metformin again pause with dehydration, acute kidney injury or hypoxia risk. SC inhibitor, ARB or diuretic review, not just stop if there is hypovolemia or hypotension. NSAID should be stopped, avoid. For GLP-1, like in this case the semaglutide or tirzepatide, defer the next dose only with persistent gastrointestinal symptoms or dehydration. Wait until the gastrointestinal symptoms improved. Protect, maintain the fluids, carbohydrates as tolerated, increase glucose monitoring, check blood glucose, blood ketones, not only glucose, because glucose will give you some false impression. Glucose may be normal, but ketone will be elevated, especially when the patient is taking SGLT2 inhibitor. Patient are suffering from type 1 diabetes. There is higher chance of ketosis risk. Never omit basal insulin in type 1 or insulin deficient diabetes. Need to individualize the dose. Then restart deliberately. When after 24 or 48 hours, patient resume to normal eating, drinking, BP and volume status stable, ketones resolved. If it was there, renal function electrolytes reviewed sometimes before restart, and restart drug by drug with named clinical and documented plan. So we need to plan which drug need to be started first and then follow. That should be properly documented. A temporary hold without restart criteria becomes permanent therapeutic inertia. Euglycemic decay, I think this is one area we need to give more emphasis. Here, glucose is not the gatekeeper. Top trigger band here, SGLT2 inhibitor, along with the metabolic stress. So, fasting or marked carbohydrate restriction, vomiting, dehydration, infection or sudden surgery, inappropriate insulin. So, all this may lead to euglycemic decay, and there could be nausea, abdominal pain, vomiting, tachypnea, fatigue. Glucose may be normal or modestly elevated. So, there, the blood beta hydroxybutyrate is important. It is very, the first thing we need to do, venous pH and bicarbonate if it is required. We can understand the acidotic state, the electrolytes, other renal function. Anion gap generally supportive, but it is not a substitute for ketone measurement while diagnosing diabetic ketoacidosis. So, beta hydroxybutyrate more than equal to 3 millimole per liter, along with acidosis, pH less than 7.3, and or bicarbonate less than 18 millimole per liter. The diagnosis is there. Glucose may be normal, but it does not exclude decay. So do not wait for hyperglycemia. Look for ketonemia and metabolic acidosis. Here we want to emphasize this concept that obesity is also a kidney disease, and this is an important contributor of chronic kidney disease. Excess adiposity increases the workload of each functioning nephron. If there is excess adiposity associated with haemodynamic and metabolic stress, glomerular hyperfiltration will be there. So as there is glomerular hyperfiltration, what happened? There will be intraglomerular hypertension, glomerulomegaly, along with lot of stress on the podocytes, leading to damage of those podocytes. Albuminuria, proteinuria will be there, and this is associated with certain adaptive focus segmental glomerulosclerosis type of lesion, and this will lead to CKD progression. So follow the trajectory, not just a creatinine snapshot, because in this case, if we stop semaglutide, just seeing the creatinine, actually we are failing to manage obesity, which ultimately cause the natural course of CKD ongoing. For that, eGFR slope, urine ACR trend, urine analysis, BP, volume phenotype, all will actually acknowledge this contribution of obesity or adiposity, excess adiposity or adiposopathy, which progress the chronic kidney disease. So obesity may explain Kavita's background, kidney vulnerability, not her abrupt 35% creatinine rise, of course. So treating obesity is actually kidney risk management. We are not reducing the belly fat and we are doing some cosmetic medicine. It is not like that. We are saving her kidney. So just 35% rise in creatinine, we should not stop semaglutide. And this was the landmark flow trial. What happened? More than 3,500 participants with type 2 diabetes, albuminuric CKD, 3.4 years follow-up. The semaglutide 1 mg once weekly arm, there was 20% relative risk reduction in terms of composite outcome of sustained more than 50% eGFR reduction, kidney or CV death. So that was the benefit of semaglutide. Not only that, the annual eGFR decline was statistically significantly better. So there was positive eGFR in the semaglutide arm compared to placebo arm. So pause when unsafe, correct the physiology, reassess, then restart, or sometimes you need to do retitration. A safety pause needs an explicit reassessment and restart plan. When we talk about flow, it had demonstrated long-term semaglutide benefit. It did not test medication interaction or restart strategies that we need to consider also. So do not continue through unsafe physiology. Do not discontinue permanently without reassessment. These two statements are equally true. Coming to this group of patients, when we are dealing with obesity, there is higher chance of heart failure with preserved ejection fraction. So just do not judge success by ejection fraction. This lady may have a very good ejection fraction, but she may have obesity-related heart failure with preserved ejection fraction. And both this semaglutide and tirzepatide had shown benefits in terms of quality of life subjectively and certain objective parameters in terms of CV death or worsening heart failure. There was 38% relative risk reduction that had been shown in the Summit trial favoring tirzepatide. So for Kavita, we need to protect today and preserve the renal function for tomorrow. Select pause, wait for the physiologic recovery, and deliberately restart. Protect today means we need to confirm the hypovolemia, check the parameters, correct the fluid deficit, temporarily held dapagliflozin, ramipril, furosemide maybe, postpone semaglutide for 1 week while nausea and poor intake persisted. Then reassess the recovery, repeated creatinine electrolyte value, reassessed the urine findings and urine ACR after the acute illness, used the eGFR creatinine cystatin-based body composition had changed. So that is why we need to check the eGFR by cystatin C, confirm that kidney function was stabilizing. Review the indication for every held medication, restarted and retitrate the appropriate disease-modifying therapy, did not automatically restore every drug at its previous dose, document the restart criteria, timing, and who is the clinical owner of that decision. That documentation is important. So these are important steps to preserve for tomorrow. So what we learned, creatinine trended toward breastline. In that case, eGFR creatinine cystatin supported that stable filtration later, and kidney protective therapy was not permanently lost. We had initiated DAPA, we had initiated SE inhibitor, ramipril. The patient was continuing semaglutide. These 4 rules to take home. Creatinine is a signal, not a verdict. Very often what happened, this type of scenario, if the creatinine rise, what we do, our dietitian colleague or we restrict the protein intake. It is not right because already the patient is on GLP-1. We know we need to take care of the protein intake there. We need to take care of their muscle mass. So lean mass need to be preserved. Lean mass need to be taken care. So for that, just blindly seeing the creatinine value, reducing the protein intake is not an good decision. It is not a wise decision. Next, whether it is linked with one drug, the clinical clock is important, the temporal relationship, the pharmacological plausibility, the de-challenge, re-challenge, and any other condition that suggests that condition is responsible for this type of event. So these all need to be considered together. And that is why we need to get the picture of the clinical clock completely, which help us to identify the mechanism behind this particular insult. When we have weight change that demands biomarker triangulation, every medication holds that needs certain criteria, as we had mentioned, which medicine in this case need to be stopped and when to restart, how to restart, who is the owner of that restarting. So success was not simply a lower creatinine, it was avoiding both the acute harm and therapeutic inertia. If we not stop the culprit drug, it will cause harm to the patient, of course, but at the same time, if we are stopping a non-culprit drug, we are also harming our patient. So we need to have a proper balance. That is why the risk versus benefit analysis is extremely crucial at every point of our therapeutic journey. So thank you very much. If we have some question or comment, please post that in the chat box.